Okay, Dr. Jeremiah,
Okay.
yeah, you can start, please. Sorry for taking you back, but
Can
we're
I be
all
heard?
good. Yes, you are audible.
Okay. Good morning, my teachers, my colleagues. I'm answering question 6 of the National Postgraduate College, November 2023. The question is, a scenario of a 45 years old taxi driver, known COPD, had recurrent cough productive of sputum for the past 2 years. He had a recent flare, which was treated 2 weeks ago before presentation. Patient also had pida edema. His FEV1 is less than 0.8, FEV1 or FVC ratio is equals to 0.61. Questions are, what additional history will you ask the patient? How will you manage this patient? And what will you do for the patient when he presents in 3 weeks' time? The scenario suggests a COPD patient who had acute exacerbation with suspected cor pulmonale 2 weeks ago and had treatment, now presents with FEV1 less than 0.8 and FEV1 FVC ratio equals to 0.61. Additional history to ask the patient. How many flares have you had in the last 1 year? Did the recent treatment you had require admission or visit to the emergency room? Then what medications were used to relieve the recent flare? These questions are important because exacerbation in COPD are classified after the event has occurred as follows: mild when treated with short-acting bronchodilators only, moderate when treated with short-acting bronchodilators and oral corticosteroid plus or minus antibiotics, severe when patient required hospitalization or visits to the emergency room. Then next question will be, what is routine medication? Then also assess his medication adherence, asking also about inhaler usage and techniques, history of smoking cigarettes will also be assessed, the pack per years, and also recent history, recent changes, if at all, in smoking habit. Environmental history will also be explored by asking of his usual taxi route, if it's dusty, and does he use face masks during work, and is he exposed to fumes due to traffic congestion? Is he exposed to second-hand smoking by other drivers in the park or passengers? What type of apartment does he live in, and his exposure to household fumes? I will assess patient current symptom using the COPD assessment test tool by asking the following question: why I'm scoring. I'll ask whether the patient still currently cough. Is it producing sputum? Does it feel chest tightness? Does it feel breathless when walking uphill or walking a flight of stairs? Is it having limitation of activity at home? Is he confident leaving the room? In respect of his condition, does he sleep soundly, and does he have a lot of energy? This will be scored by this tool. Then I will also score the patient to assess his present state of dyspnea by using the Modify Medical Research Council's tool by asking if he's breathless with strenuous activity or just shortness of breath when oral on the level ground, or he walks slower than other people of his age and becomes because of breathlessness, or he stops after just walking about 10 meters, or he's too breathless to leave the house. And this will also be scored using these two. This will help in deciding the management. Then other conditions that just that may mimic or aggravate exacerbation of COPD will be explored, like the swelling. I will ask about whether it's resolving or worsening, and is it unilateral or bilateral? Is there swelling in other parts of the body, e.g. Facial swelling, urine output, and frothy urine? That will help to rule out CKD. History of recent lung travel or immobilization of pelvic structure to rule out pulmonary embolism. Then cardiac history to rule out possible cardiac heart failure that is coexisting with the COPD by asking of cardiovascular risk factors such as hypertension, chest pain, or palpitation, also diabetes. Social history will be explored, asking for the patient's social support and also his access to healthcare and financial support. Vaccination history, influenza vaccine, pneumococcal vaccine, and COVID-19 vaccine will also be asked. How will you manage this patient? Management of this patient will involve history, as we have asked additional questions, or examination, investigation, and treatment. On the examination, we'll do a target examination, checking for cyanosis, checking for conjunctival pleurophoria in case of polycythemia, pedal edema, just as the question suggests. Then pulse rate, there may be arrhythmias, as the COPD patient are prone to. Check for the blood pressure that may give us clue to other cardiovascular risk factors. JVP may be raised in respect of the suspected cor pulmonale. Parasternal heave because of right ventricular hypertrophy, possibly for pulmonary hypertension. Heart sound there may be third heart sound in the lower left parasternal region. Respiratory rates, we check for respiratory, it may be dyspneic, and we check for SpO2. Crepitations may signify maybe existing lung infection. Then rhonchi may suggest airway limitation. Abdomen, tender hepatomegaly may also suggest the right-sided heart failure. Spirometry, we've been given ECG. Other investigation will be done to actually check out for other comorbidities that may mimic or aggravate exacerbation in COPD, such as ECG. We check for right ventricular hypertrophy, in which the R/S ratio in V1 will be greater than 1, or a deep S wave in V6 that is greater than 7 millimeter. OKP pulmonale will also be checked for. Arrhythmias, they are prone to multifocal atrial tachycardia, it will be checked for. Chest X-ray will be important to rule out possible heart failure that may be coexisting with that, as we may see cardiomegaly, upper way diversion, and the rest. Echo will be done to check, yes, the right ventricular internal diameter, and there is evidence of hypertension and increase pressure and volume, that is pressure and volume overload from the right side of the heart. NT-proBNP will help to confirm. Full blocker and differential, checking out for infection, but eosinophil count is very important because this will tell in the management. D-dimer to rule out PE. Arterial blood gas, this may indicate long-term oxygen therapy, and other baseline investigations will be done. Goals for treatment will be to reduce symptoms and to reduce risk for exacerbation. Based on the questions we've asked, from the question, we were given FEV1 less than 0.8, that is less than 80. So it means the patient can either be in GOAT 2, GOAT 3, or GOAT 4. But from the history we've asked, the importance of those histories we've asked is knowing the history of exacerbation. If the patient had 2 or more moderate exacerbation per year, or one exacerbation leading to hospitalization, the patient will be placed in Group E. Group E are group that are prone, they have high risks for subsequent exacerbation. But if the patient has 0 or 1 moderate exacerbation not leading to hospitalization, it can either be on Group A or Group B. In Group A, if he has low MRC score and CAT score. In Group B, if the patient has high MRC score or CAT score, because this assessments, this combined assessment is what will tell the choice of management of the patient. Then non-pharmacological management will be non-pharmacological and pharmacological. For non-pharmacological, if the patient is in Group A, as based on the response, the patient essentials will be to focus on smoking cessation, and also to ask questions and ensure vaccination as appropriate. Also, physical exercise will be recommended. For Group B and Group E, apart from what is suggested for Group A, pulmonary rehabilitation would also be recommended. This is a brief strategy on how to help in smoking cessation by asking the question if the patient smoke, advice on quitting, and also assess patient willingness, and also assist by other means, either social support or by other pharmacotherapies. Okay, the pharmacological treatment will be as this. If the patient is in group E, LABA plus LAMA, and however, if the eosinophil count, just like we did in our investigation, if the eosinophil count is greater than equal to 300, then inhaled corticosteroid will be added to if the patient fall in group E. If the patient fall in group A bronchodilators, either a short-acting or long-acting, can be used since they have low MRC or CAT score. But if the patient fall in group B with high score, a LABA plus LAMA is what is recommended. Oxygen therapy, these are indication for possible oxygen therapy in COPD, stable COPD patient. Partial pressure of oxygen below 55 or oxygen saturation below 88%, with or without apnea. But for this scenario, our scenario in which there's evidence of pulmonary hypertension or peripheral edema, partial pressure of oxygen between 55 and 60 or saturation of oxygen at 88% may be an indication for supplemental oxygen. Treatment of cor pulmonale, the mainstay will be to manage the cor pulmonale, which is the underlying factor. Then diuretic, but non-ambitious usage of diuretic will be advised. Then, pulmonary vasodilators are generally discouraged. Then this will be efforts to follow up of the patient, assessing for dyspnea and risk for subsequent exacerbation. Then also for pharmacological follow-up, depending on their response to dyspnea and exacerbation, this will be the modification that may be added. For instance, if a patient has eosinophil count less than 100 and is still having acute exacerbation, then roflumilast can be added to the treatment subsequently, especially if FEV1 is less than 50%. What will you do for him when he presents 3 weeks later? This is the good 2023 guideline on recommended discharge and follow-up after several weeks. So in 3 weeks later, after acute exacerbation of COPD, the recommendation for 1 to 4 weeks at follow-up is to evaluate ability to cope with his or her usual environment, review the understanding of the patient about the treatment regimen, to reassessment of the inhaler techniques, to reassess need for long-term oxygen therapy, then document the capacity to do physical activity, then also reassess the CAT score and the MRC score, then to determine the status of the comorbidities. An overview of COPD is the definition of COPD by the GOLD 2023 guideline is now an heterogeneous lung condition that is characterized by chronic respiratory symptoms. It could be dyspnea, cough, sputum production due to abnormality of the airways from bronchitis or bronchiolitis, and or alveolar, that's emphysema, that cause persistent, often progressive airway obstruction. The diagnosis, it is mandatory to have a post-bronchodilator FEV1 FVC ratio of less than 0.7. These are clinical indications suggesting diagnosis of COPD, dyspnea that is progressive over time, worse with exercise, persistent, then cough that may be intermittent and may be unproductive, history of exposure to risk factors, tobacco, smoke from cooking and eating fumes, occupational dust, and host factors such as genetic factors and the like. There are other terminologies, pre-COPD, they are now considered as individuals that may present with structural lungs lesion, such as emphysema or physiological abnormalities, including low FEV1, gas trapping, hyperinflation, reduced lung diffusing capacity, or rapid FEV1 decline, but without airflow obstruction. So they don't meet the criteria for COPD, but they, however, have some of the findings associated. These are considered as pre-COPD. Then there's this PRISM, the concept that is preserve ratio. So there's another group called the PRISMs. That is the preserve ratio impaired spirometry. These also have the ratio is preserved. They have been proposed to identify those with normal ratio but abnormal spirometry. So the ratio, the FEV1 and FVC ratio is normal, but all other spirometry findings are abnormal. So these are grouped as the PRISM group. Risk factors for COPD, environmental risk factors, cigarette smoking, biomass exposure, occupational exposure, air pollution, genetic factor, the SEPINA gene that is associated with the hereditary deficiency of alpha-1 antitrypsin deficiency. Then other genetic factors have been identified as shown. Other risk factors include aging because of the loss of lungs function as age progresses. Also, history of asthma and airway hyperreactivity, especially during childhood. Then recurrent infection, especially recurrent chest infection during childhood. Then gender, the male gender is add more risk factors. Then socio-economic status. In fact, F-way limitation have been related to poor socio-economic status. This is a proposed taxonomy on COPD that is based on the etiology. So it's called etiotype. So those based on genetic determined COPD, they are called COPD-G. Then those based on developmental abnormality, COPD-D. Then environmental factors like cigarette smoking is called COPD-C, and others are shown. The prevalence COPD globally is now associated with 3 million deaths annually due to COPD, and this is expected to get worsened as there's increased prevalence of smoking in low and medium income countries. Clinical presentations, just as we saw in the case presentation, the dyspnea, activity limitation, and or cough with or without sputum production. And they may experience acute events, just as the flare in the case scenario. Pathophysiology include airflow obstruction and gas trapping, pulmonary gas exchange abnormalities, and pulmonary hypertension may subsequently develop. They are prone to exacerbation, and they are also prone to morbidity. So in all cases of COPD, the presence of other comorbidity is very important because they may mimic or aggravate exacerbation. Just to remind, these are common medications that are used for COPD in the maintenance of COPD. The short-acting, which are the SABA, the SAMA, and the LAMA. They are shown on the table. Exacerbation of COPD is defined as exacerbation of COPD is defined as an event characterized by an increased dyspnea and or cough and sputum that worsen in less than 14 days, and which may be accompanied by tachypnea and or tachycardia, and is often associated with increased local and systemic inflammation caused by infection, pollution, or other insults to the airway. Currently, exacerbation are classified after the event has occurred as this, as mentioned earlier.
Dr. Jeremiah, can you round up in 2 minutes?
Okay, sir. Okay, but presently it has been proposed that this chart can be used to classify severity of COPD while the event is going on, not just after the event has occurred. This mild, there are various, as shown in the table, moderate. So this is still a proposal from the, is the wrong proposal from the GOLD 2023 guideline. Treatment of COPD, it involves using short-acting inhaled beta-2 agonists and or without short-acting anticholinergics. Maintenance therapy, as shown, most of those maintenance therapies shown on the table can be employed. Then in patients with severe exacerbation, systemic corticosteroid has been shown to improve the FEV1. Antibiotics, when indicated, can shorten recovery, especially when there is evidence of infection, reduce the risk of early relapse, treatment failure, and hospitalization. These are confounders. As mentioned, these are other conditions that can contribute or confound presentation of acute exacerbation, pneumonia, pulmonary embolism, heart failure, pneumothorax, and myocardial infarction too. Differential diagnosis of COPD are shown: asthma, congestive heart failure, bronchiectasis, tuberculosis, and others. These are other causes of chronic cough. So whenever a patient presents with chronic cough, these are other conditions to consider. I want to thank you very much for listening. Thank you.
Thank you, Dr. Is open for comments. Dr. Tanimu, you can go ahead with your contribution. Dr. Tanimu.
Thank you very much, Dr. Jeremiah, for this very good presentation. As they told you, they have already given you the diagnosis as a non-COPD, a driver. So you need to exhaust about, since they said he's a driver, he is prone to exhaust fumes. Those smoke of the driving due to the driving activity. So he may need, that may be the recurrent precipitant of his chronic, of his exacerbation. So you may need to also, it can even come down to change of job or use of a better car without producing that very good big smoke. Sometimes the cars may be because of the car, the exhaust fumes may be the one that does smoke. Then he may need a change of job, or you have to explain that he may need change of job or use of car with lesser smoke, all sort of that. And also pertaining that oxygen therapy, they may need you to explain use of domiciliary oxygen. You don't need to even say oxygen therapy. You have to just say using of domiciliary oxygen therapy. There are about three parameters you use in that one. Use of arterial, use of oxygen, arterial oxygen value of arterial partial pressure of oxygen. And they have already told you that this patient has pedal edema. Then use of what? Features diagnosis of what? Right ventricular failure, copulmonale, and also polycythemia. So those three parameters, they need you to be cutting up the values and the relation for the indication that will support you to have to assess that this patient have indication for domiciliary oxygen, like saying that right copulmonale with polycythemia is an indication. Then arterial partial pressure of oxygen, all this, you have to be correlated with those three parameters to come out that to assess that this patient has that indication. So it's not only that you say oxygen therapy, they need you to be saying domiciliary, because now she presents you 3 weeks after, meaning that He is now stable. You need to access him for the. Thank you. Verbal enlarge is a very good presentation.
Yeah, thank you, Dr. Tanimo, for your contribution. Dr. Fatima.
Sorry, Dr. Fatima, before you speak, this is Dr. Shit, sorry. The last speaker, when you talked about change of job or getting a better car, that may be a bit insensitive to the patient. It's easier to say you can try and improve condition of work, meaning that it could be the route that he's driving through. Maybe that route is still under construction, and there is a lot of asphalt and dust on that particular road. So perhaps he needs to change routes, okay? Or maybe he's an interstate driver, and then you could say, okay, maybe for the meanwhile, perhaps you should switch to driving within a particular state where you don't have to go on the major highways. It also may be a bit insensitive to tell the person to change his car. We all know the economic situation of the country, even though we want to say the ideal thing. They expect us to put it in the context of where you are. We are in Nigeria, and of course, we know the situation of the country. So it may be difficult for him to get a better car. What you can do is try and improve the current condition of his current vehicle. Okay? Oh, is it possible to get the AC fixed so that he can wind up his windows? Oh, is there a leaky exhaust? Oh, perhaps he should have his exhaust checked and, whatever leakage plugged or welded or whatever. Okay? Or improve the condition of his engine or things like that. Okay? So rather than just going straight into buying a new car or changing his car completely.
Thank you, sir, for your contribution, sir. Dr. Fatima.
Yeah, thank you very much, Dr. Jeremiah, for that excellent presentation, and thank you, Chief Shitu, for the excellent addition. Dr. Jeremiah, I think the way you approach the question, in answering it, in exams, you don't have all this time to talk about all the investigations in details. You must be able to manage your time very well. No matter how much you know, if you cannot manage your time, once time is off, then that is over. So I think with the issue of the treatment, the additional history was very good, but the issue of treatment, you have to say that it's you need a multidisciplinary approach, because this patient need social workers, the pulmonologists, the cardiologists, and all that. Then you briefly mentioned about the investigation, then go straight to classifying your patient into what stage of COPD is that patient, then you treat accordingly. So with regards to investigations, you may not have time to talk about all those investigations, but the most important ones, you understand. Then the treatment, you mentioned them, 1, 2, 3, 4. You mentioned all the treatment because you are given categories of all our guidelines and all that. I think in answering the question, you need to just go straight to, I will do this, I will do that. Then the issue of assessing the patient 3 weeks later. This is where the assessment for long-term oxygen comes in. You assess the inhaler technique, you assess if there is any underlying infection, then you consider a vaccination, influenza or pneumococcal vaccination. Then you also assess the patient. You do other investigations when the patient comes back, including the spirometry, the peak flow rate, the ECG, echo, chest X-ray, because you need to assess for a complication like pulmonary. So this is one of the things that you need to do when the patient comes 3 weeks later. Thank you very much. This is my little addition.
Thank you.
Thank you, Dr. Fatima, for your contribution. Dr. Temitope, you raise your hand.
Good morning, teachers and colleagues. Thank you very much for the very lucid presentation. I just want to add regarding the assessments 3 weeks post-exacerbation, You mentioned it, but it may be good to actually spell it out. So COPD is a disease associated with comorbidities. So it's also important to screen for the comorbidities that are known to occur in patients with COPD and the follow-up visit. So things like acid reflux, GERD, obstructive sleep apnea, depression, and then ischemic heart disease, because most times the risk factor for COPD is commonly smoking. So there are also, it's also important to screen them for that, and also lung cancer. So in the follow-up visit, it's essential to actually actively look out for these comorbidities and address them if present. Thank you.
Yeah, thank you, Dr. Temitope, for your contribution. Let me start reading from the chat box. Okay, Dr. Success said occupational therapy and physiotherapy are other non-pharmacological management strategies. That's why management should be multidisciplinary. Dr. Momodu said, one, preclinical COPD represents patients with airway obstruction, FEV1, FEVC, FVC less than 0.7, but no symptom, or there are mild respiratory symptoms such as cough, sputum, or dyspnea. The cutoff COPD assessment test is used to evaluate this. The 2024 Gold Guideline emphasizes chronic self-care model and the need for non-pharmacological measures, especially pulmonary rehabilitation, which is multidisciplinary. Category A to quit smoking, B and E to quit smoking and pulmonary rehabilitation. Then he said, also note we now have for them vaccination for RSV, pertussis, shingles, COVID, and the usual pneumococcal influenza vaccine. And then he said ARA assessment is also key. Then Dr. Ozo said the most important risk factor for COPD among women in Nigeria is exposure to biomass fuel. So these are the comments I could see from the chat box. And then while others are applauding you for a wonderful presentation. Any other contributions? Any other comments? Dr. Ekele said, ensure patients for long-term oxygen therapy are not smoking to avoid fire incidents. Thank you all for your contribution. Over to our teachers. I don't know if there are other comments or contributions from our teachers before we go to the next presentation. The next candidate should share his or her screen for anyone that is ready.
For a waste of time, let's move over. If somebody's ready, somebody should be ready. Ready 7:43.
Anyone ready?
Dr. Atta, please help us read out the names of people that are here to present that are in the class. Let's hear from them why.
Okay. Okay. So for West Africa.
Hello.
Yes. Yeah.
We might need to start changing some of these things since we are recording these things and they'll be on YouTube. I might not be able to edit some things out. So